Excellent. I'm learning a lot about bloody theme songs. I haven't heard half these before. Okay, so next team up is Nebraska. Sorry, Nittany Lions, Penn State. So who's going to be leading off there? And your slides.
Hello, we are Team Penn State. I want to first tell you about John. John had been brought to the hospital for a serious heart condition. Thankfully, he had a smooth recovery and was to be discharged a few days later. His discharge instructions looked like this. The instructions he'd been given contained complex medical terms and were confusing. He had difficulty understanding what he needed to do to prevent a hospital readmission from his condition. He ended up having another emergency event and returned to the hospital a few months later. Unfortunately, John's story is not unique. In fact, according to the CDC, 9 out of 10 adults in the US are affected by health literacy issues, which is defined as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others.
Reduced health literacy is clearly rampant throughout our country. About 20% of adults read at a 5th grade reading level or below. Information that's beyond the intended reading level often causes individuals to feel confused and powerless, and it can also lead to worsened health outcomes and increased costs for the healthcare system. Black American, Hispanic American, and Asian American populations all have significantly greater disparities in reading levels in comparison to individuals in the white American population. Limited health literacy not only disproportionately affects those with little or no education and low income, but also the majority of seniors and young adults who have the lowest health literacy levels of all ages. Another study found that the percent of the population with below basic literacy was doubled in the Medicare and Medicaid populations.
Our solution is Simplify. Simplify is an artificial intelligence-based tool that will be integrated into the EMR so that during the time of discharge instructions are analyzed to assess for the level of complexity and readability. Suggestions will be proposed for simplified sentence structures, substitution of text, and more concrete instructions. Physicians would ultimately accept or reject the changes, ensuring a human is kept in the loop. Our goal is to empower patients to take control of their health outcomes as they navigate the health system to better understand their medical conditions, medication dosing instructions, and their timeline for follow-up. The Simplify vision is simple. We're aiming to improve readability of materials, improve outcomes, have better transparency for patients, increase patient empowerment and engagement, and ultimately improve health outcomes and health through communication. These are a few examples of the discharge instructions we saw on one of the earlier slides. If you turn your attention to the one on the bottom, it reads, if you have chest pain and it persists, please take nitroglycerin every 5 minutes for 3 doses. If your pain persists, call 911. Simplify would suggest the following language. Take nitroglycerin if you have chest pain. You can take it every 5 minutes up to 3 times. If you still have chest pain, call 911.
A product like Simplify makes economic sense as well. As many as 65% of preventable readmissions are associated with poor health literacy and inadequate understanding of discharge instructions. Other studies have shown a 50% reduction in readmissions after manual improvements in readability. A product like Simplify would help providers better care for their disadvantaged patients, addressing the up to $238 billion annual burden on the US economy due to poor health literacy. Simplify could be marketed to hospitals, which would benefit from reducing readmissions and avoiding the penalties that rocked 83% of hospitals last year. Electronic health record systems that incorporate our product would see improved value and marketability. And if we can demonstrate improved outcomes when our product is implemented, health insurances may play a role in incentivizing the use of our product. All in all, the opportunities for a medical readability product like Simplify are promising.
As you can see on this chart, there's a number of competitors within the market. Unfortunately, they all fall short of our solution due to a minimal feature set, subpar performance, or a lack of novel technology. What makes our product truly revolutionary is the bidirectional encoder representations from Transformer's deep learning model, which is the engine that will power our neural machine translation. This is a state-of-the-art artificial intelligence architecture which leverages the capability of the model to learn contextual relationships between words in a text. This produces the most accurate translation to date, not just of single words, but of entire phrases.
Sorry. Our system is a hybrid, rules-based artificial intelligence system that can be broken down into 3 major stages, each performing distinct tasks and using distinct technologies. So in the first stage, we just evaluate the reading level of the text at the level of words, phrases, and sentences. The system will flag difficult or ambiguous words or phrases for potential rewrites. The second stage uses an ontology search algorithm to identify potential word-level substitutions and clarifications of difficult medical concepts. In this stage, the system will identify appropriate word-level replacements using either more common synonyms or generalizations. So for example, it would replace myocardial infarction with heart attack, and for rotator cuff, it might suggest inserting the explanation part of the shoulder. It may also prompt the provider for clarification of ambiguous instructions. So for example, suggesting a length of time clarification for phrases like if pain persists. The final stage is a data-driven AI model for phrase and sentence level simplification. This stage takes full sentences and phrases and automatically suggests simplifications that could include reduced grammatical complexity, splitting off of independent clauses as new sentences, and additional word-level substitution. We'll use transformers, which are a state-of-the-art technology used in machine translation by companies like Google, that automatically capture contextual information and full sentence semantics for our simplification. If you look at this small example, it changes the phrase, if your pain persists, to if you still have pain. Notice that this isn't just a word level substitution. There's a change in the grammatical subject. There's a change in the case of the word your from possessive to nominative, and the word pain moved to the end of the phrase because it's now the object of the verb. This is the sort of thing you can't do just by substituting out difficult words with a dictionary. Ultimately, we're going to evaluate our system in 2 ways, using human judges to do a qualitative evaluation of the system on discharge instructions and a quantitative evaluation using existing reading level metrics.
Our development timeline over the next few months focuses on creating a minimally viable product. Between May and June, we're going to plan to identify content libraries and natural language processing framework for testing. We're also going to begin designing the interface for physician interaction. By June to July, we plan to begin testing our algorithm and word replacement libraries. We'll also be performing concurrent user testing for utility of the simplification and expanding the simplification library itself. And finally, by July to August, we want to have a minimally viable product.
As Ravi mentioned, testing will be performed within our institution to measure performance, as well as to receive direct feedback from providers and patients. As with all software, it's theoretically infinitely scalable. Also of note, we'll pursue FHIR specification, allowing for increased interoperability. In terms of revenue, we'll initially implement a revenue sharing model with participating hospitals in which only a proportion of the amount saved from reductions in readmission or length of stay will be paid out, likely as a trial period. This lowers initial risk for the hospitals and conveys confidence in our product. Long-term, we plan to pursue a subscription-based model. We would also tap programs such as the new technology add-on payment from CMS, or pursue partnerships with Highmark Health Insurance for unique revenue opportunities. One of our main ethical considerations is non-malfeasance. We want to make sure we're not harming patients by misconstruing provider instructions. That's why all algorithm-generated discharge instructions are final approved by a physician. Our core technology, which improves with each iteration due to a constantly expanding training data set, will be applied to a number of different clinical tools in the future.
Our novel AI tool, Simplify, addresses a major healthcare disparity by automatically enhancing the readability of discharge instructions. By targeting avoidable readmissions and facilitating more robust communication, we strive to reduce the overall costs and improve patient outcomes, ultimately simplifying healthcare for our most vulnerable populations.
Bridget. Really nicely done, and on to questions.
So great presentation. I think this is a really important problem. I'm curious with the solution, because my understanding is that many of the text is actually a certain way because of like regulatory and legal challenges. So if your product is constantly changing the text that the person may see, how do you plan on keeping up with that from just a regulatory legal perspective? Because if somebody may misread it, then potentially they could sue you or the hospital. So I'm curious about the legal liability. And I have 2 more questions, but I'll hold them.
Yeah, so just your first question here, great question. And we consider this very heavily in thinking about developing this product. Ultimately, the changes are suggested, and the provider accepts or rejects those changes for the discharge instructions they're typing out to the patient. This is not changing discharge summaries, which are between providers. This is looking at the communication between the provider and the patient themselves. And so if the provider feels that their instructions or the recommendations are not being adequately communicated by the text that's suggested, they can reject that suggestion.
Mm-hmm. There is still some legal liability then that the provider would take on, because essentially they're signing off on that. So just something to consider. The other thing was the revenue model. So you said that you would make the money based on if like the patient didn't get readmitted, for example. How would you measure that? Because how would you know it's based on your intervention?
Sure. So, I think what would happen is in that initial trial period, we would try to measure at least, the basal rate at which there's readmissions, and see if there's a difference there before we actually, market it outside the institution. So we would probably find a initial rate and then find a change in the rate, for the patients that had that particular intervention, and that's how we would find the difference there.
Okay. And then my last question is, you talked a lot about disparities in understanding kind of like the instructions in the beginning slides, but this solution would be applied to everybody. So in a way, how does this specifically address a health disparity? It sounds like it addresses like a challenge in the health system overall, rather than a specific disparity, if that makes sense.
And I'll let you take this.
That's true that health literacy is very far reaching and is affected by factors, not only the ability, just education, but also where one person lives, their employment status or income, their race can also be a factor because so based on federal studies. I think it is a disparity because certain populations are still more affected, and it's important that we address that these disparities exist in order to have interventions to address those issues. So for example, seniors, they use the most healthcare services, have more chronic conditions, take more medications, and the cost from that is tremendous to the healthcare system. And so by recognizing that one population, for example, we can take action to help improve their outcomes and help make sure that they are getting the care that they need.
Okay, thank you.
And just to piggyback off of that, I guess our goal is really more of like a blanket, kind of all encompassing issue. So we're kind of trying to stop any type of like downstream effect that would happen right before it actually happens, right in its tracks, and addressing when patients leave the hospital or after an appointment, if they don't understand their healthcare instructions, that we address it right then and there. And we do know, as Alyssa said, that there are several populations that struggle more with understanding those healthcare instructions, and that does increase cost to the healthcare system then. So definitely both a systems issue, but also we're addressing those healthcare disparities as well.
So this is Shannon, if I could jump in for 1 second. So you have listed Hispanic Americans and Asian Americans as a target population. What about if you don't address patient, or if you don't communicate with patients in their preferred language? Obviously it can be difficult regardless of literacy. So how are you going to handle the primary language of preference for your patient base?
Can you jump to the future direction slide, please? And go ahead, Christian. Yeah.
So, I mean, what we got actually, how we're going to use the BERT model was from neural machine translation. And before they were using it, well, before we thought of using it for essentially our project of simplification, they were already investigating this for language translation. So I think while our product right now is specifically for simplification of the text, I think naturally the next step would essentially be utilizing for language translation. Certainly what could happen before we go there is just utilizing a current language translation model for the simplification itself. Obviously, we want to make sure there's no mistakes when it comes to kind of phrase differences. But I think that's more of a future direction for us to be able to apply this technology for not just kind of simplification of text, but also for translation of language to language to be able to be more applicable to different populations, as you said.
Thank you.
I was going to say the same thing about the language, but I was concerned about the cultural appropriateness of the language as well. We're talking about a system that could be difficult to implement because of the different ways that different cultures receive and interpret the information.
And so during that, so to kind of address the question, during the trial period, we would have, as I mentioned, kind of feedback from the different patients, from the providers. And because this is an AI model that's going to be constantly being iterated, it's going to, at least we predict that through the feedback of the patients, we will be able to kind of improve that training model and to be able to overall broaden it so that it essentially encompasses, more of what the entire population, it would more, I would say it would have a better representation overall. And I think currently FDA doesn't allow kind of iterations to be, every iteration has to be FDA approved. You can't change your training model in between, but I guess during this trial period before, it's FDA approved, we would just, kind of work that out during the trial process.
I would add also, sorry, I would just want to chime in on that answer, that it's not just about, we would be able to test it with different populations, but we would also be able to draw on different data sources. So for example, there are large scale corpora. I think there's one from the University of Oregon that has large amounts of texts written by, in regional African-American language, for example. And there are other corpora usually collected by linguists that show language used by different cultural groups. So we could draw on those kind of data sets when we're coming up with rules for what kind of word or what kind of phrase is maybe too difficult or a source of confusion, something like that.
I first want to say this is really interesting and an important problem. Thanks for the presentation. And then I guess I was struck by the fact that by specifically going to discharge instructions, you may have inadvertently stumbled on one of the most studied areas in the sort of hospital admission process, which is that we're constantly working on these discharge instructions. There's layers of people that it goes through. There's regulatory issues. On some level, I guess I wonder how you will navigate that, just even in terms of clinician burden. Like when you do discharge instructions, it goes through like 4 sets of people before it goes to the patient. Does every single person have to do the editing? Like, how does this work? Is this all on the physician? I guess I'm not sure who's going to actually go through the process of changing all the words as needed.
So ultimately, it's the discharging provider who writes the instructions and finalizes that, while the other caretakers on the team also, if they're med students, residents, and fellows, they may contribute to that. But let's say in the community model, it is the provider who's going through those instructions finally and finalizing them. The nurses and other caretakers may read those to the patient, but we did consider heavily problem of having increasing clicks, increasing burden on the provider. Ultimately, with this, by correcting their language, we wanted to save them time in any confusion that the patient would face. And by decreasing admissions, it would decrease the overall burden on the healthcare system. So hopefully a positive feedback. Yeah, sorry.
All right, we'll call that a time. So again, great presentation, great discussion. Thank you very much. Nice work. And I think the next team up is Minnesota, University of Minnesota Golden Gophers. And we're gonna give our judges some time to put their scores in with some questions in the meantime.
Thank you.